Welcome back to the Deep Dive. Today we're talking to you as if you're preparing for your MD anesthesiology exams, and I'm your senior faculty. Our mission is, well, it's laser-focused. We are creating the definitive exam-ready review of Etomidate.
Exactly. This isn't just about knowing the drug. This is about being able to write that perfect 20-mark answer for, say, a Gujarat University paper where this drug's big paradox is almost always a question.
It's unparalleled strength versus its single really critical flaw.
That's the one. And you're right, this is a guaranteed high-yield topic. If you're preparing for any major anesthesiology exam, you cannot afford to have a surface-level understanding of this drug.
We have to get past just saying it's cardiovascularly stable.
Absolutely. You need to dig into the pharmacodynamics, the specific enzymes it hits, the controversies, all of it. So we're going to structure this deep dive precisely like a model answer you can use. #tag1. Introduction, exam framing.
Okay, let's start at the very beginning, the basics. How do we define etomidate for that opening line in an exam? What is it, chemically speaking?
Right, the definition. So chemically, etomidate is classified as a carboxylated imidazole-containing compound.
Imidazole. Okay.
And that imidazole nucleus is really the key. It's what fundamentally distinguishes it from the other common IV induction agents you're used to.
So not like propofol or the barbiturates.
Not at all. Think about it. Propofol is an alkyl phenol. Thiopental is a barbiturate. Etomidate sits in its own chemical category.
And in terms of what it does, it's a functional classification.
Functionally, you'd categorize it as a non-barbiturate hypnotic agent, and that defines its main clinical effects.
Yeah.
It gives you a very rapid induction of a hypnotic state.
But, and this is an important point, no pain relief.
Zero. It has no significant analgesic properties, which is a fact that can sometimes be overlooked in the heat of the moment.
Now, a detail examiners love is stereoisomerism. How is the drug actually presented?
Ah, good point. So etomidate comes as what we call a racemic mixture. But, and this is the crucial part for your answer, the anesthetic effect is almost entirely in the R+ isomer. R+, yes. That R+ enantiomer is about 5 times more potent than the S version. And that stereoselectivity is vital because it points directly to its mechanism. It tells us it binds to a very specific structured receptor site.
Which we'll get to later as the GABA-A receptor.
You've got it.
So that chemical uniqueness brings us to its most famous quality, its cardiovascular stability. Why is this drug seen as the absolute champion of hemodynamic stability among induction agents?
It really is the champion, and that's the whole reason it's still in our toolkit despite its flaws. The stability comes from a unique combination of things.
Yeah.
First, and this is the main point, it has almost no effect on the sympathetic nervous system.
Or the baroreceptor.
Or the baroreceptors. So the body's own ability to regulate heart rate and vascular tone it stays intact during induction. At normal clinical doses, myocardial contractility and cardiac output are pretty much unchanged.
But you do often see a small drop in blood pressure, don't you?
A slight drop, yes. You might see the mean arterial pressure, the MAP, dip by maybe up to 15%. But, and this is the critical distinction, that drop is because of a mild reduction in systemic vascular resistance.
So it's not hurting the heart itself.
Exactly. It's not a direct negative inotropic effect on the heart muscle, which is what you see with propofol or thiopental. That lack of direct cardiac depression is what makes it the go-to agent for really sick, hemodynamically compromised patients.
Since we're framing this for exams, what are the common ways this question pops up?
It usually comes in one of two flavors. You either get the broad 20-mark essay or a very specific focus question.
What's the broad one look like?
It'll be something like, describe the pharmacokinetics and pharmacodynamics of etomidate. Describe briefly its role in clinical practice. That's the kind of question that covers everything we're going to talk about today. You need a really structured, systematic answer for that.
And the focus questions, you said they're a trap.
They can be. We've seen questions like, describe the pharmacodynamic effects of etomidate on the cardiovascular, respiratory, endocrine, CNS, and hepatorenal systems. If you forget one of those systems, you're dropping marks.
And is there one system that's always the main event?
Always. It's the endocrine effects, the adrenal suppression. That's the part that is always singled out for detailed discussion. You absolutely have to be ready to explain that mechanism in depth. #tag2, chemical and pharmaceutical properties.
All right, let's pivot to the technical details, the chemistry that explains all this. You said it's an imidazole derivative. Can you give us the full picture?
Sure. The full chemical name is a bit of a mouthful. R plus pentylethyl 1H, imidazole 5, carboxylate sulfate. But what's really important for you to understand is that imidazole nucleus,
Okay, why is that so important?
because that structure allows the molecule's solubility to change depending on the pH. It has a pKa of about 4.2.
Which is quite acidic compared to body pH.
Very. And because our physiological pH is around 7.4, it means that when you inject it, most of the drug is in its non-ionized lipophilic or fat-soluble form.
And that's the key to its speed.
That's the key. High lipid solubility plus a large non-ionized fraction is the chemical recipe for lightning-fast entry across the blood-brain barrier.
Okay, let's talk about the formulation. This is where that infamous pain on injection comes from. How is the drug presented?
The standard presentation is a clear, colorless solution. It's 20 milligrams of etomidate in 10 milliliters of fluid, which gives you a 2 milligl or 0.2% solution. Now, the problem isn't the drug itself, it's the solvent.
Propylene glycol.
The original formulation uses 35% propylene glycol, and that creates a massive physiological problem.
Let's quantify that. How bad is it?
The problem is its hyperosmolality. The propylene glycol makes the solution have an osmolality of around 4,600 milliosmoles per kilogram.
4,600 compared to plasma, which is what, under 300?
Exactly. Human plasma is about 280 to 290. So this huge osmotic gradient is what's directly responsible for two very common side effects.
Which are?
First, severe pain on IV injection, which you can see in up to 30% of patients. And second, superficial thrombophlebitis, which can happen in up to 20% of cases.
And there's another issue, isn't there? With red blood cells.
Yes, hemolysis. This hyperosmolar solution can cause a transient breakdown of red blood cells. Now, in a healthy patient, that's probably not a big deal. But if you have a patient with pre-existing kidney disease or someone with fragile red cells, like in sickle cell disease, it's a real concern.
Is there a rule for that older formulation?
There is, and you should mention this. With the propylene glycol formulation, the total dose should really not exceed 30 milliliters to try and mitigate that hemolytic risk.
That's a huge list of problems just from the vehicle. How did the industry fix this?
They did what they did with propofol. They created a lipid emulsion. The newer preparation, often called Etomidate-Lipuro, suspends the drug in a lipid vehicle, and that has basically eliminated the severe pain and venous irritation. It's much, much better for the patient.
And just quickly, what about stability and storage?
It's a very stable compound.
Yeah.
The propylene glycol was actually there to improve stability in the first place. Commercial preparations hold up really well, so, stability is not a major clinical concern or a common exam question. Tag 3, mechanism of action.
Okay, so we know what it is and how it's packaged. Now let's get to the core mechanism. How does this unique chemical translate into such rapid, potent hypnosis?
Well, the fundamental mechanism of etomidate's action is all about the brain's main inhibitory neurotransmitter, which is GABA.
Gamma-aminobutyric acid.
Right. Etomidate works as what we call a positive allosteric modulator. It basically makes GABA better at its job. It enhances the inhibitory effects of GABA by increasing the flow of chloride ions through the GABA-A receptor channel.
Do we know exactly where on the receptor it binds?
We do. The GABA-A receptor is a big protein complex, a pentameric channel. Etomidate binds to specific sites on that protein, particularly on the ones that have the I-2-2 subunit combination.
And its stereoselectivity, the R plus isomer being more potent, that supports this idea.
Absolutely. The fact that one isomer fits so much better than the other confirms its binding to a very specific, highly structured pocket on that receptor, which then increases the receptor's affinity for the GABA that's already there.
I've heard there's a kind of dual action mechanism depending on the concentration. What's that about?
This is a really important distinction to make. At clinical doses, the amount you need for induction etomidate acts as a positive modulator. It helps the GABA that's already there work more efficiently.
So it's an amplifier.
Exactly, it's an amplifier. But at very high superclinical concentrations, it can actually activate the GABA receptor channel directly without any GABA present. It becomes a full agonist.
So how does this GABA enhancement translate into the clinical state of anesthesia?
It leads to very rapid CNS depression because it crosses the blood-brain barrier so quickly. Thanks to that lipid solubility we talked about, hypnosis happens incredibly fast. We're talking 1 arm-brain circulation time, often less than a minute.
And it does this by depressing the reticular activating system.
That's right. It quiets down the reticular activating system, which leads to that rapid loss of consciousness and sedation. And that same GABA facilitation also explains its other properties.
With anticonvulsant effects.
Precisely. By boosting that chloride influx, you're stabilizing neuronal membranes, making it harder for runaway electrical activity to happen. This gives etomidate quite potent anticonvulsant properties.
Okay, but then we have the big paradox in the CNS myoclonus. If it's a depressant, why do we see all these excitatory movements?
Ah, the million-dollar question. Examiners love this one. The leading theory is that it causes disinhibition.
Disinhibition.
Yeah. So instead of depressing everything in the brain uniformly, it might selectively knock out certain inhibitory pathways. First, specifically, the ones that normally keep our extrapyramidal motor system in check.
So you're taking the brakes off the motor system.
That's a perfect way to put it. You silence the inhibitory neurons, the underlying motor circuits become disinhibited, and the result is those involuntary, often quite jerky myoclonic movements. It's pretty unique to etomidate.
And finally, what about memory? It's a powerful amnesic.
It is. The amnestic effects are thought to come from its action on GABA-A receptors that contain the I5 subunit. Hitting those receptors seems to impair long-term potentiation, or LTP, which is the basic cellular mechanism for forming memories. So you're unconscious, and you can't form memories of the event. #tag for pharmacokinetics. Very high yield. All right, let's talk pharmacokinetics. This is one of those three big cornerstone sections for any long exam answer on a drug. The whole rapid on, rapid off nature of etomidate is completely explained by its kinetic profile.
So how do we model the drug's journey through the body?
The movement of etomidate is best described by an open three-compartment model. This just means we think of it moving from the central compartment blood and vessel-rich organs to a peripheral one and then eventually being eliminated.
Let's just hammer home the onset one more time. Why is it so fast?
The onset is, for all practical purposes, immediate. You're looking at one arm brain circulation time, maybe 30 to 60 seconds. And it's driven by those two factors we keep coming back to. High lipid solubility and the fact that most of it is non-ionized at body pH, so it just zips across the blood-brain barrier.
Okay, now for the most important teaching point here. What makes you wake up after a single shot?
This is the absolute high-yield distinction you have to make. After one induction dose, the effect is terminated almost entirely by redistribution, not by metabolism.
Redistribution.
The drug physically moves out of the vessel-rich group, the brain, the heart, and gets taken up by inactive tissues, mostly muscle and fat. Once it's in the muscle, it's not causing hypnosis anymore. The initial distribution half-life is incredibly short, something like 2.7 minutes.
So the body's tissues must really soak it up.
They do. The volume of distribution, the VEAT, is pretty large, somewhere between 2.5 to 4.5 liters per kilogram. And that just confirms that there's a lot of tissue uptake, which creates that reservoir for the rapid redistribution that makes you wake up.
Okay, before we get to metabolism, let's talk about protein binding. It's highly bound, right? What does that mean for a really sick patient in the ICU?
It's very highly protein bound, about 75 to 76%, mostly to albumin. And this is a huge clinical point for ICU patients. If you have a patient with sepsis or liver failure, they're often hypoalbuminemic. They have low albumin.
So more of the drug is free?
A lot more. A drop in albumin means a big increase in the free, unbound fraction of etomidate. And since only the free drug is active, a standard dose in a patient with low albumin will have a much bigger, more profound effect. You have to reduce the dose.
That makes a lot of sense. So how is the drug finally cleared from the system?
The metabolism is very fast and efficient. The main pathway is hydrolysis of the ethyl ester side chain. This reaction, which happens both in the liver and by estereses in the plasma, turns the active drug into an inactive carboxylic acid metabolite.
So the clearance rate must be pretty high.
It is. Clearance is high, around 18 to 25 millikilocalorie. The inactive metabolites are then cleared mostly by the kidneys, with less than 3% of the drug excreted unchanged.
Okay, here's a point of confusion. You said recovery is unaffected by liver problems, but the half-life is longer. How do we explain that for an exam?
That's a great question. It tests conceptual clarity. For a single bolus, the patient wakes up because of redistribution out of the brain. The speed of the liver doesn't really matter in that initial 5 to 10 minute window.
For an infusion?
But for an infusion, or just for clearing the drug from the body completely, the liver matters a lot. In a patient with cirrhosis, for example, the volume of distribution is bigger, and the elimination half-life can be twice as long. The total time the drug hangs around is much longer.
And that brings us to the context-sensitive half-time. This always gets compared to propofol.
Always. And etomidate's context-sensitive half-time is actually shorter than propofol's, especially after longer infusions. So purely from a pharmacokinetic standpoint, it would be a better drug for a brief infusion if
it weren't for the endocrine problem.
Exactly, if it weren't for the adrenal suppression. But that comparison is a classic exam topic.
One last thing on kinetics. What about in extreme states, like hemorrhagic shock?
Animal studies have shown that etomidate's pharmacokinetics are remarkably stable in low-flow states like shock, which is not true for other agents. This intrinsic stability is a huge reason it's so valued in trauma. And just remember, for the elderly, smaller VEED, decreased clearance means they're more sensitive. You have to cut the dose. #tag5. Pharmacodynamics.
Let's shift gears now to what the drug does to the body systems. Pharmacodynamics. And we have to start with its biggest strength, the cardiovascular system. #cardiovascular effects.
The clinical benefit here is, well, it's hard to overstate. Etomidate is unique. It causes minimal, and I mean minimal, changes in heart rate, stroke volume, or cardiac output. That's its signature.
And the mechanism is that it leaves the sympathetic nervous system and the baroreflexes alone.
It leaves them alone, which is why that small drop in blood pressure we see is so much more benign than the hypotension from propofol.
Explain that difference. Why is a 15% drop from etomidate better than a 30% drop from propofol?
Because the heart muscle is protected. Propofol causes hypotension from vasodilation and from directly depressing the myocardium. It's a negative inotrope. Etomidate doesn't do that. The mild drop in vascular resistance is manageable, and crucially, the myocardial oxygen supply to demand ratio stays fantastic. The heart isn't starved of oxygen during induction.
But we have to remember the analgesia caveat. What happens if you use it alone for intubation?
If you use etomidate alone and then perform laryngoscopy, which is a huge stimulus, you will see a big surge in heart rate and blood pressure. The drug is a hypnotic, not an analgesic. You're just seeing the patient's unblocked stress response.
So you have to pair it with an opioid.
For a smooth induction in a cardiac patient, absolutely. You need a rapid-acting opioid to blunt that sympathetic surge. #tag respiratory effects.
What about the lungs? Does etomidate cause a lot of respiratory depression?
Relatively speaking, no. It causes less ventilatory depression than propofol or the barbiturates. Apnea can happen, for sure, especially if you inject it really fast or combine it with a lot of opioids, but it's less common.
Is there a typical breathing pattern you see after giving it?
There is, yeah. You often see this characteristic pattern of a brief period of hyperventilation right after you push it, which is sometimes then followed by a short spell of apnea. The result is usually just a small, transient rise in PaSO2.
And for patients with asthma or COPD, is it safe?
It's an excellent choice. It does not cause histamine release, unlike some other drugs we use, so it's considered very safe in patients with reactive airway disease. #shag cerebral effects.
Okay, the brain. The CNS profile of etomidate is, well, it's very good for managing brain swelling, but there's a really complex caveat you need to understand about neuroprotection.
So let's get the numbers. How much does it reduce cerebral blood flow and metabolic rate?
Etomidate is a potent, direct cerebral vasoconstrictor. A standard dose will drop cerebral blood flow, or CBF, by about 34%. And it drops the cerebral metabolic rate for oxygen, CMRO2, by even more, about 45%. That's a deep metabolic suppression, similar to what you see with barbiturates.
And the clinical result of that is a drop in ICP. A big drop. Because of that powerful vasoconstriction, it can acutely lower a high intracranial pressure by up to 50%. That's hugely beneficial for patients with brain swelling.
So you drop the ICP, but what happens to the overall cerebral perfusion pressure, the CPP?
The CPP is well maintained, and often it actually increases. And this is the magic formula. You're dropping the pressure inside the head dramatically while having almost no effect on the systemic blood pressure that's pushing blood to the head. The net result is a much better oxygen supply to demand ratio for the brain.
Okay, hold on. If it does all that, why isn't it universally called neuroprotective? This sounds like an exam trap.
It is the biggest exam trap in this section. The controversy comes from the timing of these events. The vasoconstriction, the drop in blood flow, often happens before the maximal drop in the brain's metabolic rate.
So there's a period of mismatch.
There's an uncoupling, yes. And in a situation like a focal stroke, where one part of the brain is already starved of blood, that severe vasoconstriction could actually make things worse. It can clamp down on the blood vessels that are trying to supply the injured area.
So it could potentially extend the ischemic injury.
Some animal studies suggest that in focal ischemia, it can actually aggravate tissue hypoxia and acidosis. So while it's fantastic for managing global brain swelling, the evidence doesn't support using it specifically for ischemic neuroprotection. You have to make that distinction. #tag endocrine effects, important exam point.
All right, this is it. The single most important, most controversial part of the discussion. The adrenal suppression is etomidate's Achilles heel. We need the mechanism precisely.
Okay, so the problem is the drug's effect on the adrenal cortex. Specifically, it inhibits key enzymes in the pathway that makes steroid hormones. And this inhibition is dose-dependent, and importantly, it is reversible.
Which enzyme is the main target?
The primary target is a mitochondrial enzyme called 11-beta-hydroxylase,
11-beta-hydroxylase.
also known as CYP11B1. It does hit another one, 17-alpha-hydroxylase. But the 11-beta-hydroxylase inhibition is what causes the profound clinical effect.
So walk me through the cortisol pathway. What does that enzyme do, and what happens when etomidate blocks it?
So 11-beta-hydroxylase does the final critical step in making both cortisol and aldosterone. It converts 11-deoxycortisol into cortisol. When you inhibit that enzyme, you've effectively shut down the production line for the body's main stress hormone and its main salt-retaining hormone.
Cortisol and aldosterone.
Right. And you get a buildup of the precursor molecules like 11-deoxycorticosterone.
The sources all stress this massive potency disparity. How strong is it as an enzyme inhibitor compared to a hypnotic?
The disparity is it's staggering, and you must emphasize this in an exam. Etomidate is far, far more potent as an enzyme inhibitor than as a hypnotic. You can measure adrenal suppression at plasma levels below 10 nanograms per milliliter.
10. And what do you need for hypnosis?
For hypnosis, you need plasma levels over 200 ng/ml. So the drug doesn't even need to be at a concentration that keeps you asleep to be shutting down your adrenal glands.
Wow. And how long does that suppression last after just one induction dose?
After a single standard bolus, the inhibition lasts for a surprisingly long time. You're looking at about 4 to 8 hours, though some hormonal effects can be detected for up to 72 hours. And that period of transient adrenal insufficiency is the entire clinical dilemma of this drug. #tag 6, clinical uses.
Okay, so given this double-edged sort of a profile, where does etomidate actually fit in modern anesthesia?
Its niche is entirely defined by cardiovascular compromise. Its main role is still the induction of general anesthesia for very high-risk patients. The standard dose is usually 0.2 to 0.6 milligene kilograms.
Let's get specific about the patient populations where it really shines. Let's start with cardiac patients.
Etomidate is the go-to agent for induction when you are genuinely anticipating a cardiovascular collapse, or in patients with really poor cardiac function.
So severe valve disease, bad ischemic heart disease.
Exactly. Or for procedures like a valve replacement, or even an emergency cardioversion in a patient who's crashing. Its ability to protect that myocardial oxygen supply-demand balance is its greatest asset in these cases.
And what about in the emergency department or the ICU?
It's invaluable for rapid sequence intubation, or RSI, in patients who are hypovolemic or in shock. In trauma, in sepsis, maintaining blood pressure is everything. Etomidate gives you the best chance of getting that tube in without causing a catastrophic drop in blood pressure.
And finally, neuroanesthesia.
It's an excellent choice for neurosurgical induction, specifically because it controls that high ICP while maintaining cerebral perfusion. So for craniotomies, for brain tumors, it's a very effective tool.
But again, with the caveat that it's for ICP control, not for ischemic neuroprotection.
You have to remember that distinction. It's great for pressure, but its protective role is limited. And there's one interesting paradoxical use. During epilepsy surgery, it can actually be used to help surgeons find the seizure focus. It sometimes activates those epileptogenic spots on the brain, helping them map out the area they need to resect. #tag 7, dosage and administration.
Let's do a quick run-through of the practicals of dosing. This is classic Viva exam territory. What's the standard adult induction dose?
The standard dose is typically 0.3 milligrams per kilogram, given IV. The range is about 0.2 to 0.6. And it's really important to remember that if the patient has had any premedication, like an opioid or a benzo, you have to reduce that dose.
How do you adjust for, say, an elderly patient or someone who's critically ill?
For the elderly, you have to cut the dose. Their increased sensitivity is pharmacokinetic. They have a smaller initial volume of distribution and slower clearance. For the critically ill, especially in a shock state for RSI, we often use the lower end of the range, 0.2 to 0.3 milligauge kilograms. The priority there is maximizing hemodynamic stability above all else.
And what about the speed of injection? Does it matter?
It does. It has to be given intravenously, of course. And a rapid injection is standard for RSI because it gets you to that therapeutic plasma concentration almost instantly. The trade-off, though, is that pushing it fast increases the chance of myoclonus and transient apnea. #tag 8, advantages of etomidate. All right, this section is essentially the defense of etomidate, why we still keep it around.
Okay, let's list the 3 core advantages that have to be in any good answer.
Number 1, without a doubt, unparalleled cardiovascular stability. That has to be your first point. It maintains heart rate, cardiac output, contractility, because it leaves the sympathetic nervous system and baroreceptors alone. For a patient who can't tolerate any drop in blood pressure, this is a lifesaver.
Number 2.
Minimal respiratory depression. It causes less ventilatory depression than most other agents, and it's safe in asthma because it doesn't release histamine.
And number 3.
The favorable cerebral profile. It drops CBF, CMRO2, and ICP, all while keeping the cerebral perfusion pressure stable or even improving it. There's a huge win for almost any neurosurgical patient.
Is there any other key clinical advantage?
Just that rapid recovery due to redistribution. It allows for a very prompt neurological assessment after a procedure, which can be really valuable in acute head trauma or stroke cases. #TEG99. Adverse effects and complications. Exam favorite.
And now we get to the flip side. The reasons etomidate is not the perfect drug. Let's start with the shaky movements. Myoclonus.
Myoclonus is extremely common. The reported incidence is all over the place, from 0 to 70%, but clinically you'll see it in more than 30% of patients. And the mechanism, as we discussed, is that disinhibition of the extrapyramidal motor system.
The examiner is definitely going to ask how you prevent it.
They will, and you manage it prophylactically. Giving a small dose of a potent short-acting opioid like sufentanil or remifentanil about a minute before you give the etomidate is very effective. You can also use midazolam or even IV magnesium.
And in an RSI situation?
In RSI, it's a non-issue because the neuromuscular blocker you're giving at the same time will completely prevent any visible movements, even if the CNS disinhibition is still happening.
Okay, what about the pain on injection and thrombophlebitis?
These are really formulation dependent. With that old propylene glycol solution, pain was common. You could reduce it by using a big vein or giving some lidocaine first. But the real solution is just to use a lipid emulsion formulation, Etomidate-Lipuro, which has pretty much solved that problem.
Postoperative nausea and vomiting, PONV, is another big one.
A huge one. Etomidate is highly imidogenic. The rate of PONV is high, somewhere in the 30 to 40% range, which is way higher than with propofol. And that high PONV rate is what really limits its use for day case surgery, where you want patients to feel good and go home quickly.
Okay, we have to circle back to the adrenocortical suppression. This needs the most detail. We know the mechanism. What are the clinical consequences you need to stress in an answer?
The clinical significance is profound. That transient shutdown of cortisol and aldosterone production happens at the exact moment the patient needs those hormones the most, during major surgery, trauma, or, crucially, septic shock.
Cortisol is the body's stress hormone.
Right. It's essential for maintaining vascular tone and regulating inflammation. A temporary inability to produce it can, potentially, compromise the patient's ability to maintain their own blood pressure.
This brings us to the really scary part, the controversies from its use in the ICU. What happened in the 1980s that got etomidate infusions basically banned from critical care?
In the 80s, people tried using etomidate as a continuous infusion for sedation in the ICU, especially for septic patients. And what they found was a significant increase in mortality in those patients receiving the infusion.
And that was linked directly to the adrenal suppression.
It was. The prolonged, deep, and persistent shutdown of cortisol production was deemed an unacceptable risk. So the clinical consensus is now absolute. You do not use continuous etomidate infusions in critically ill patients. It's contraindicated.
But a single bolus for RSI is still common. What's the current, more nuanced view on the mortality risk from a single dose?
This is where the debate is, and where you need a sophisticated answer. Early studies suggested a single dose, with its 4T hours of suppression, didn't increase mortality. However, more recent, larger meta-analyses paint a much more sobering picture.
What do they show?
They suggest that even a single dose of etomidate is associated with a greater relative fatality rate, maybe around 20%, in the absolute sickest of patients, those with a very high predicted mortality. So while it's still the best drug for immediate hemodynamics, you have to be aware that you are inducing a transient adrenal insufficiency.
So what's the clinical takeaway?
The takeaway is that in a patient with severe septic shock, you should anticipate the need for proactive glucocorticoid supplementation, like a low dose of hydrocortisone, right after you intubate, to help them through that window of suppression. Showing you understand that nuance is what separates an average answer from a great one. #10. Contraindications and precautions.
So based on all that, let's just clearly list the formal contraindications and warnings.
The biggest and clearest one is this. Prolonged sedation or continuous infusion is a strong contraindication in any patient with sepsis or severe critical illness because of that proven link to increased mortality.
And what's the precaution for a single dose?
The single-dose precaution is that you have to carefully weigh the immediate benefit of hemodynamic stability against the risk of that transient adrenal suppression. The practitioner has to be ready to manage the hormonal fallout that's going to happen.
Are there other specific patient groups to be wary of?
Yes. You should probably avoid it in children with suspected adrenal insufficiency and sepsis. You also need to be cautious in patients with a history of epilepsy. Even though it's an anticonvulsant, it can sometimes activate seizure foci, which is unpredictable. And of course, that old propylene glycol formulation should be used with caution in anyone with fragile red cells, #tag 11. Comparison with other induction agents, exam-oriented. Right? No exam answer is complete without comparing etomidate to its main competitors. It really helps define its specific niche. #tag etomidate versus propofol.
Let's start with the big one, propofol. Where is the comparison most dramatic?
It's all about hemodynamics. Etomidate is just vastly superior. It maintains blood pressure, cardiac output, and perfusion pressure way better because it doesn't directly depress the heart. Propofol, on the other hand, can cause a significant, sometimes catastrophic drop in blood pressure.
But where does propofol win?
Propofol wins on the side effect profile, hands down.
Yeah.
Lower PONV, no myoclonus, and absolutely zero adrenal suppression. In terms of the CNS, both are effective, but propofol is less likely to stir up seizure activity. #tag etomidate versus thiopentone, barbiturates.
Okay, what about against the classic thiopentone?
Again, hemodynamics is the big differentiator. Thiopentone is a significant direct cardiodepressant. Etomidate is not. Etomidate also causes less respiratory depression. And while both are good at lowering cerebral metabolic rate, the big difference is recovery. You wake up much faster after a single dose of etomidate because of that rapid redistribution, whereas thiopentone can leave you feeling groggy for longer. #tag exam-oriented comparison points. The trade-off.
So if an examiner asks you for the one-line clinical selection principle, the trade-off, what's the model answer?
The decision really hinges on the patient's cardiac reserve versus their physiological stress load. You choose etomidate when hemodynamic stability is the absolute #1 priority in shock in severe heart disease, and you are willing to accept the risk of transient adrenal suppression to get that stability.
And propofol.
You choose propofol when avoiding PONV and endocrine side effects is critical, and you are confident you can manage the potential for hypotension aggressively. The most experienced clinicians only reach for etomidate when they believe propofol would be too dangerous. #tag 12, Viva points and common exam traps.
Let's do some rapid-fire questions now, the kind of stuff they'll hit you with in a Viva to test your real-world thinking.
Okay, let's do it. The classic. Why would you pick etomidate over propofol for a hypertensive trauma patient? Your answer has to focus on the preservation of the sympathetic nervous system and baroreflexes. It maintains the patient's own vascular tone, which maximizes perfusion to the brain and heart. It's all about immediate stability.
The inevitable endocrine question. What is the most serious side effect of etomidate and why?
The answer is definitively adrenocortical suppression.
Yeah.
And you have to immediately follow up with the mechanism, inhibition of the 11-beta-hydroxylase enzyme, leading to decreased synthesis of cortisol and aldosterone.
And they'll test management. What can you give before etomidate to prevent myoclonus?
You can say pre-medication with a short-acting opioid like remifentanil, or a benzodiazepine like midazolam given about a minute beforehand.
Okay, now for the traps. The common mistakes people make.
The biggest trap is to say that etomidate is generally neuroprotective. You have to qualify that. It is protective against changes in ICP and CPP. But you must acknowledge the evidence that it can worsen focal ischemic injury. The examiner wants to see that you can distinguish between global pressure management and focal tissue protection.
What's the second big trap?
The second trap is saying that single-dose adrenal suppression is clinically irrelevant. That's an outdated view. You have to show you're aware of the recent data suggesting it may increase mortality in the sickest patients, and that you might need to give glucocorticoids in response.
So what's the perfect, safe summary of the drug's use for an examiner?
You have to emphasize the drug's dichotomy. Say that the suppression is reversible and dose-dependent, lasting 48 hours, and that a continuous infusion is absolutely contraindicated. Then you affirm that a single dose is still the standard of care for high-risk patients, where maximizing immediate hemodynamic stability is a life-saving move. That shows true synthesis. #tech13. Diagrams and exam presentation.
For the written exam, structure and presentation are so important. What diagrams should a student be ready to quickly sketch out?
You really need two. First, be ready to draw a simple plasma concentration time curve. Show that rapid initial peak, then the very steep drop as redistribution kicks in and the patient wakes up. Labeling the concentrations for hypnosis and awakening gets you bonus points.
And the second, more critical one.
You must be able to draw a simplified cortisol biosynthesis pathway. You don't need every single step, but you must show cholesterol going to 11-deoxycortisol and then to cortisol. The whole point of the diagram is to put a big X over the 11-beta-hydroxylase step to show where etomidate inhibits it. That proves you understand the mechanism, not just the name of the side effect.
Okay, let's just revisit the ideal structure for that big 20-mark essay.
Use clear, numbered, and underlined headings. Make it easy for the examiner to give you marks. It should flow logically. Introduction, physicochemical properties, pharmacokinetics, pharmacodynamics.
With a system-by-system breakdown in the dynamics section.
Exactly. CV, respiratory, CNS, and a big detailed section on endocrine. Then clinical uses, adverse effects, with a focus on the ICU controversy, and finally a quick comparison with the other drugs.
And what are the headings that absolutely have to have detailed content?
You must deliver real depth on pharmacokinetics, pharmacodynamics, cerebral effects, and then 2 separate big sections on the endocrine suppression itself and the related ICU controversy. #Tag 14. Summary and exam conclusion.
All right, that brings us to the end of our deep dive. Let's finish with a final checklist, the 10 or so bullet points you should have memorized before you walk into that exam.
These are your high-yield facts. 1. Chemistry. Imidazole derivative R+ isomer is active. 2. Formulation. Old version in propylene glycol causes pain. New lipid emulsion, Lipuro, solves this. 3. Mechanism. Positive modulator the GABA-A receptor. 4. PK. Rapid onset recovery is from redistribution, not metabolism. 5. Metabolism. Rapid ester hydrolysis to an inactive metabolite. 6. Cardiovascular. Unmatched stability, ideal for hemodynamically unstable patients. 7. Cerebral. Lowers CDF, CMR2, and ICP while maintaining CPP. 8. Adverse effects. High rates of myoclonus and PONV. 9. Endocrine. Potent reversible inhibitor of 11-beta-hydroxylase causing 4 to 8 hours of cortisol suppression. 10. Infusion use. Absolutely contraindicated in the critically ill due to increased mortality.
Perfect. And can you give us that ideal synthesizing conclusion paragraph for a long answer?
I would write something like this. Etomidate remains an indispensable induction agent owing to its unparalleled cardiovascular stability, making it the agent of choice for patients with severe cardiac compromise or hypovolemic shock, while its potent suppression of adrenocortical function via 11-beta-hydroxylase inhibition prohibits its use for prolonged infusions and mandates caution in septic patients. Its immediate hemodynamic benefits often outweigh this risk when used as a single bolus for rapid sequence induction in high-risk scenarios. Its unique profile demands a careful risk-benefit analysis tailored to the individual patient.
That's a perfect articulation. It shows true mastery of the drug's complex role. And that brings us to our final provocative thought. Given that the cardiovascular stability is so good, but the adrenal suppression is so bad, researchers are actively trying to fix the flaw.
Exactly. The holy grail would be an agent with etonidate's hemodynamics, but none of the endocrine baggage. And this has led to new drugs like methoxycarbonyl etomidate or MOC etomidate.
MOC etomidate.
Yeah. It's been chemically engineered to be cleaved by esterases so fast that it's metabolized before it can cause prolonged adrenal suppression. The early studies show it works as an anesthetic, but crucially, does not significantly inhibit 11-beta-hydroxylase. So the question for you to think about is, does this kind of targeted drug design represent the future of hemodynamically stable induction? If it works, the etomidate we know today might just become a historical footnote.
A fascinating thought. For now, though, you need to know the original drug inside and out. Go structure your answers, understand the nuances, and ace those exams. That's all for this deep dive.